I'm just going to start the recording so that we can post this afterwards. Okay, so we're going to talk about safe wards and the reassurance intervention. Personally, I feel like I need a little bit of reassurance myself after that late start. To me, it seemed that nobody had turned up, so I had nobody on my attendees screen. So I thought I'd been completely abandoned, and I was feeling rather sorry for myself. But there you all were, just waiting to appear at the flip of a button. Okay. Reassurance intervention. Let's talk just first of all quickly about what it is and it isn't. The central idea here is that when there's been some kind of event on the ward which might be potentially distressing, upsetting or anxiety provoking for other patients as well as for the people who've been involved in the incident, that we should go around and offer some reassurance and explanation to everybody on the ward who might have A, witnessed it, B, heard it at a distance, C, heard about it from another patient, and give them an accurate and reassuring account of what's gone on and what the staff have been doing. So typically we're thinking of here if there's been any incident of shouting, and if there's been any incident where a patient has had to be manually restrained, or when there's been any kind of fuss or kerfuffle, or where an object has been broken or something has been thrown around, etc., etc., etc. Now, we usually, once we've dealt with these situations on the ward, we certainly manage to reassure the patient who's been involved in the incident. We will often go away and have a quick debrief amongst ourselves, amongst those people who've been dealing with the incident, and talking about how we might have handled that, or perhaps congratulating each other on managing to have handled it really well. We seldom, though, actually manage to take the third step, which is to go out there and reassure the other patients on the ward. So that's what reassurance is about. And the theory behind this, or the explanation as to why this works to reduce conflict and containment, is that there's a lot of contagion happens between patients on the ward. The main mechanism, or there are two main mechanisms for that contagion. For if one incident happens, another incident then is more likely to happen. One is the fear and anger of those who might have witnessed the incident. They themselves might feel personally threatened, or they might be angry about what they've perceived. The other mechanism is copycatting, in that one patient will copy what another does. Now, the evidence for contagion actually occurring on the wards is there's quite a bit of it in the research literature. Some comes from my own research, some comes from other people's research. When we did interviews of patients who'd absconded from the ward, there were a few of them that told us they absconded following an incident on the ward that had made them frightened, particularly. These are things that would, we would view as being really low-level incidents, like a bit of shouting going on the ward. But for another patient, these can be quite shocking and quite frightening. Remember, they don't always know what to make quite of the strange behaviour of the other patients around them. And they might be feeling quite anxious because of reasons to do with both their symptoms and because might be their first, or the ward might be a strange environment to them. So certainly some people abscond following incidents on the ward, and we pick that up during our interviews. We also pick this up statistically, though. If there's one officially reported incident in the course of a week, then a ward is much more likely to have a second reported incident in that same week than it is had no incident actually occurred. So there's a statistical clustering, if you like, of these incidents. Some of that might be because it's the same patient misbehaving, but some of it is certainly due to contagion. And the other area where there's very strong evidence for contagion is around suicide attempts, where very clearly if there is one suicide attempt on a ward, or even a completed suicide, then there is more likely to be another, and the next patient is more likely to use exactly the same mechanism. So there are several studies where people have given accounts of clusters of suicides, and each patient has subsequently attempted to use exactly the same method, sometimes successfully so, use the same method as the previous patient. So there are some other mechanisms why reassurance might work, might cut that contagion link, but it's also an opportunity to clarify what the staff are doing in their actions. So it's a chance for us to explain to patients what the ward is about and what we're trying to do, and to make visible to them the whole purpose of what the ward is for, about keeping people safe while they're ill in a respectful and dignified manner. And that gives us a chance to explain the things that we do that don't appear to be that way at a superficial look. So to another patient who sees a manual restraint, might see that as being 3 or 4 members of staff ganging up against a patient. So this is a chance for us to give our explanation of what it is exactly that we're doing, and to assert that and to make sure that the patients on the ward understand what we're all about. But if we manage to reduce people's anxiety, then that also means, because anxiety is a known trigger for psychotic and other symptoms, if we reduce the anxiety, we can reduce their symptom levels. We can reduce their symptom levels, as we know through lots of other previous research, but also from the Safe Wards model. Symptoms themselves make conflict and therefore containment more likely. So you kind of see you get into a kind of a beneficial cycle here if you can wind down everybody's anxiety following an incident. And lastly, this is a platform to teach patients psychological understanding and interpersonal skills in their behavior towards each other. So it's an opportunity to kind of explain to patients different ways of understanding each other's behavior, rather than the patients themselves blaming each other or judging each other or each other's behavior as bad or wrong. We can generate that psychological understanding amongst the patients, then they're much less likely to argue with each other. They're much less likely to judge and argue with each other. There will be less conflict and containment, again, as we know from the Safe Wards model. So this is how the reassurance links up to, in fact, several of those domains in that overall hexagonal Safe Wards model. So thinking about reassurance fidelity, is getting it right, what exactly it is. So it is heightened staff awareness of ward events that can make patients agitated, anxious, upset or angry, and taking action so that they don't get agitated, upset or angry following those ward events. And it's kind of a basic consideration for people who have been witnessing potentially distressing events. And once again, I would emphasize here, this is things that are potentially distressing to patients, not things that are necessarily potentially distressing to us. We're very used to the kind of low-level harassment and incidents and atmosphere and aggro, if you like, which is quite prevalent on an acute psychiatric ward. Patients aren't necessarily so. Even if they are used to it, they might yet still make them feel profoundly uncomfortable and anxious being in that unpredictable environment. So if we can reassure them and tell them that we're looking after their interests and looking after them, lower their anxiety, that's going to have a number of benefits. What reassurance isn't is just simplistic, routinized telling patients things will be fine when they come to the office door and express a worry. Everything's going to be okay sort of comment. It's clearly not going to work. Neither is it really about gossiping about other difficult patients and things that have gone on. I was going to show you the video, but I think seeing as we're off to a late start, we'll pass over without doing that. I'll just say that there is a video on YouTube on the Safe Wards channel that you can look at. Jeff is sticking his hand up, so okay, Jeff, what are you asking? Jeff, what do you want to know?
I haven't actually. Sorry, I just haven't got anything on my screen. I was wondering, are you going through slides, or and if other people can see slides?
Screen sharing. Yes, I've been going through slides. Right there. Oh, this is getting off to a cracking start, this webinar.
Have some reassurance, Len. It's
Uh,
very interesting.
uh, 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 I'm going to run away and hide when this webinar is over. I'm going to switch you off. I'm going to keep everybody switched off so they can't criticize me. Right, you've all got your microphones switched off. That makes sure that you can't criticize everything I'm doing, which is going wrong this morning. To carry on with reassurance, let's get back to my presentation, which you haven't been seeing, which you now can see. I'm thinking now a bit looking at reassurance and long-term implementation of reassurance and what this might mean. And now over the next few slides, I'm going to pause at the end of the slides and ask if anybody's got any comments or questions that they would like to add. So starting with long-term implementation of reassurance, I can't see any issue or problem with trying to do this in the long term. In fact, I would see this as being very necessary as something to continue in the long term. There's no point at which you would want to drop or stop this particular intervention. The risk is, though, of tired, half-hearted, superficial implementation through routinization. The risk is that it becomes like much of the other reassurance that we give patients, in that we give it so often that we become habituated to it ourselves, and there is no actual genuineness to the things that we're saying or that we're doing. The other risk, particularly with this particular intervention, when we're required to go around and check with all of the other patients and make sure that they have a good and accurate understanding of what's gone on and have received some reassurance where it's been necessary. The risk is that we go around and do that in a half-hearted fashion. We don't see all of the patients. We don't try very hard. We don't say very much. We get stuck in the same forms of language. So in fact, the heart of what we're trying to do dies, even though the outer appearance of it stays as if it's there. So I thought one of the things that perhaps you could do on a ward to try and keep this type of intervention alive would be to share patient narratives and stories about inpatient care experiences to keep our empathic perception fresh. Because as I say, we're in these environments as staff all the time. We're working 5 days a week, long shifts. We do it day in, day out, week after week, year after year. And we are very, very used to the environment and to most of the things that go on within that environment. Admittedly, patients can always surprise us from time to time, but most of the time, this is a known quantity to us, and there are lots of things that we stop perceiving from a naive point of view. Suppose if you want to think about this from a naive point of view of what the patients might feel, you might get your new student nurses, ones who've never been on the ward before, to tell you what it's like, tell you the way that they perceive things. But patient narratives will do, in fact, just as well and will do better if you can access them, give you an idea or refresh for you what it's like to be a patient on an inpatient psychiatric ward. So challenge training I put down here as well. Randomly choose a patient and ask a staff member to talk about how they perceive their admission and events on the wards for 5 minutes. It's a kind of a variant on a research scale we tried at one time called the 5-minute speech sample. But this time you're picking a staff member and a patient, and you're asking the staff member to put themselves in the shoes of that particular patient and say how that particular patient perceives their admission and the events that are going on the ward, say, during the past week. It's an empathy and perception exercise for each member of staff, and I suppose you could turn this into a kind of a group effort as well. First member starts with trying to say what they would think the patient was thinking, and then so on. The whole group of staff could then put in what they felt was their point of view on the way that that particular patient saw things. And of course, if you really wanted to take it to the end of the process, you could then appoint somebody to go and check with the patient whether you'd got their perception accurately. How do you get staff to keep doing it amidst the frantic, busy activity of an acute ward? Well, during the Safe Wards trial, we had this as an overt inclusion as an agenda item during the nursing shift handovers. In other words, what we said to people is during the handover, you had to consider, had there been any events during the course of your shift which might have been anxiety-provoking for patients, and had you carried out the necessary reassurance of the rest of the patients? And if it hadn't been carried out, you could then plan to do so. However, you could develop other mechanisms creatively to overcome the inattention that eventually follows a routinized practice. And I'm going to open this to the floor now and see whether you've had any difficulties with getting people to keep on doing this, and if you have any responses on the suggestions that I've got down on this slide. So put your hand up, as it were, and I will unmute your microphone and you can go ahead and tell us what you think. Okay, Jeff, you have the floor.
Ben?
Yeah, you're there.
Yeah, it's just something that's been ticking in the back of my head as you've been talking. I was just thinking, is there any link with the Quirk and Elliott thinking about the patient perspective? Because they did the research about how patients keep themselves safe and mechanisms that patients actually use on a ward. And I think it was about how patients look for reassurance from each other. Was there anything in that kind of links in?
Well, certainly that's part of the background research that shows that patients do get anxious and upset on the ward, similarly as did our absconding research and all of the other research that I made out. I remember, I think, probably saying to Alan Quirk, who conducted that research, that if I was in charge of a wardenership, I would be horrified to think that I had a patient on my ward who was frightened of other patients, and I didn't know, A, I didn't know anything about it, and B, we and the team weren't actually doing anything about it. Yeah, carry on.
Yeah, I was just thinking that because I think a big theme of this is for staff to actually think in the patient's shoes, because I mean my practice, I think this kind of link between somebody self-harming on the ward and then go around checking everybody was very much a staff that we used to do that routine practice, but it was very much staff determined. And I think the beauty of this is we're constantly about thinking what's it like to be on the other side of the door kind of thing, and that the more we can get staff to constantly be thinking, what does this look like from that perspective? That's reassurance. It's very much about that, and about then patients kind of understanding that we actually do think from their perspective rather than just sort of in the office kind of thing.
Yeah, I've got no disagreement there. Is there anybody else who would like to say anything? Oh, you're all keeping quiet. So I'll carry on to the next slide. So does reassurance need any adjustment depending on the speciality of the ward? Well, thinking about CAMS, Child and Adolescent Mental Health Services, then certainly the level of comprehension of the children and their ability to psychologically or socially understand the behaviour of other children or the behaviour of the staff might be compromised by their developmental stage. These are just some ideas, because personally I've never worked in a child and adolescent mental health service, but as a parent of children I know you've got to couch your explanations in a way that they can understand, that's age appropriate, and in the language that they understand. So presumably some thought has to be given to how you're going to actually deliver reassurance interventions to children, depending on their level of comprehension and, in fact, ability to concentrate and actually receive the information that you're giving them. In forensic psychiatry, I did wonder how this intervention might relate to the rehabilitation goals for the patient involved in any incident, and for the members of the patient community. What was I thinking of there for the patient? I think for the members of the patient community, clearly you want to see within a forensic ward that patients can contain the anxiety and potential anger and frustration generated by the behavior of other patients, and that they have a level of understanding and can show a level of empathy about the difficult behavior of other people. And therefore delivering reassurance becomes partly a rehabilitative and even therapeutic goal within that kind of context. As you're also delivering an intervention which is likely to change the way in which other patients respond in future to the person who's been involved in the difficult behavior, then that might alter also the rehabilitation goals for that particular patient themselves, how they understand their own behavior, how they respond to the way that other people now respond to them after they've behaved in that way. So all of that's worth a little bit more thought, I think. I don't know whether there might be more to think about in relation to index offence, how the patient's behaviour now relates to their index offence that got them into hospital in the first place. And again, there might be then another layer to reassurance in that case. And then I started to think about what would be the levels of knowledge between patients about the reasons for their admission and their symptomatology. And there might need to be potentially a lot more care put into thinking about what sorts of explanations are shared amongst patients for the behaviours of each other. I'll come back to that in a minute, and I can see there's some questions coming up on the screen here. And finally, does reassurance need any adjustments for older people? Well, for a functional illness ward, I wouldn't think it requires any adjustments at all. But how this would quite work in a dementia ward, I'm not entirely sure. And I'd like to hear from people who've implemented safe wards on a dementia ward. I suppose, again, it comes down to explanations, ability to take in information and understand the behaviours of other people and of the staff. So I'm going to open it to questions and comments from the floor, but we'll start with the comment from Ole, which I haven't read yet. To beat the superficialness, it's important to keep interested in the patients and the patient's understanding. Do you have some advice on how to keep the staff members interested and curious? I'm just going to park that question for a while because it refers to the previous slide. Let's stick with the reassurance adjustments for now, and then when we've finished dealing with that, we'll come back to this particular question, Ole. So any questions or comments about adjustment for reassurance? Okay, Rachel, here you go. The floor is yours.
Hello, can you hear me?
Yeah, we can hear you.
So one of the wards that we've implementing it on in the service that I work for is a residential aged care unit, and there's predominantly patients there who have dementia. And really, I think for the staff, how they've interpreted it is that obviously, depending on how lucid the person was, they would offer that explanation as best they could, but it's more the presence aspect that's playing more of the part, and having that reassurance in a physical sense rather than just offering an explanation and having the presence sort of all together, as it's often used in more of the adult acute settings. So that's what we have done here, but I'd be keen to hear if anyone else has done anything different.
Okay. I was just thinking as you were speaking, Rachel, perhaps touch plays a greater role in the elderly?
Yeah, I would, and certainly the physical presence for sure, and I think it's more a case of, as you were saying before, being aware of your patients and how they might respond in certain situations, and then, you know, behaving accordingly. Because similarly, you would still get patients who wouldn't want you to be that close to them necessarily after an incident and would actually prefer to have space. But I think just having that awareness and that presence more with people with dementia is well, that's what the staff have told me is probably going to be more effective, and B, I suppose a lot easier to evidence that they're doing that, and they're doing that every time. So that's our experience here.
Okay, thanks, Rachel. Georgie is making some comments under the question, so I'm going to invite you onto the floor, Georgie. Do you want to say what you're thinking at the moment?
Yeah, I was just thinking kind of the cognitive impairment is really quite marked. I work on a ward with people with dementia, really quite profound dementia, but they're still able to feel the anxiety, so they're not quite sure what's driven all of these horrible feelings that they're having, but they know that they're scared, they know that they're fearful. So really in agreement with the previous speaker, saying that physical presence is there, you know, your body language, yes, touch appropriately, but just to be there and to know who needs the reassurance, knowing, you know, the personal profiles, the life stories of who you're looking after, really important stuff.
Okay, thank you, Georgie. That's there are some good nurses out there. Anybody else? Have we got anybody from forensics with us today? Anybody working in forensic psychiatry? The more I thought about reassurance in relation to forensic psychiatry, the more profound and actually quite difficult it started to get. Or a shame, it doesn't appear that we've got anybody with us today. Okay, so before we pass on to the next slide, we're going to come back to Ole's question, which is how do you keep staff interested in the patient and the patient's understanding? Okay, I'm gonna then put that one out to the floor. How do you keep staff interested in the patient? Stick your hand up if you think you've got an answer to that question. Jeff reckons he's got an answer to that question. Okay, Jeff, go on, tell us.
Well, I haven't got an answer, but I really like the idea of staff giving an account from the patient's perspective. I thought that really kind of appealed to me. I could see that happening in handover or something. You know, picking a patient and, you know, what is the ward thinking about? What does the ward look like from their perspective? Yeah, you know, I think things to, and that would also be very interesting, or even kind of, you know, doing that in a role play. You could interview somebody from the patient's perspective. You could kind of introduce some kind of novel ways that staff, in my experience, you know, find quite interesting, quite useful, and also you come away with a slightly different perspective, particularly if you have got the multiple kind of person who's being difficult. You know, what does the ward look like from their view? Might be a good way to kind of take reassurance to another level.
Okay. Anybody else want to have a shot at this? I'm still sat here mulling this over in my mind because I'm thinking of some of the more burnt out staff that I've worked with over the years. how do you kind of reignite the passion in that person for actively seeking and understanding of patients? And I think that's quite a complicated question in individual cases, Ole. I think in terms of the team, we've talked about some activities the team could do, or some patient narratives that could be accessed. Obviously, there's loads of written material these days from patients about how they see things that could be used. But in terms of individual members of staff who you believe have a problem still being interested in and curious about patients, then it becomes more a matter of management and supervision. That's kind of a different kettle of fish, really. If I was a manager of a ward where I felt perhaps one or two of the staff were no longer as curious or expressing as much effort or making as much effort to understand the patient's point of view, then I'd be opening that as a question within their supervision sessions. I'd be saying to them things that I had noticed about their behaviour in the past few days, past few shifts I'd working with them, and exploring with them curiously what was their perception and understanding of what was going on. And you might then uncover some potentially quite good or big reasons as to why those particular members of staff are in that particular position at this particular time, and you could work out ways together of managing that. I suppose that would be my answer. Anybody else want to have a shot at this? Ah, Rachel is there. There you go, Rachel. The floor's yours.
This is just something that's popped into my head, and this certainly wouldn't probably work on its own. But the Department of Health here in Victoria, they did a Safe Wards Train the Trainer sessions, and part of the Reassurance section of the Train the Trainer session, they did this activity about walking in other people's shoes, and it was really interesting. And since I've come back to my service and done that with the staff that have been working on wards implementing Safe Wards, it just opens up a conversation, and really it's basically a series of questions, and they have a card with some details on, and they stand forward if they would answer yes to the question or stay where they are. And then we talk about it afterwards, why did you answer yes or no to a series of questions, which is basically, quite ordinary questions around, would you, for example, be approved a bank loan? Would you be well respected in the community? And it's really interesting conversation starter. So maybe something like that would maybe help as a group, unless if you have a specific staff member, as you were saying, then more one-to-one would help. But if you had a group of people, that's quite a good conversation starter, and you could do some work around thinking about putting yourself in the person's shoes, understanding that person's perspective, because I think it's quite easy to, as you were saying, to lose sight of how frightening it can be for our patients, and how that obviously the responses that we see are very much related to that. So perhaps something around that, I don't know. I found it quite useful in our service.
Okay, thank you, Rachel. Anybody else want to have a shot at this? Yeah, Jeff is back. There you go, Jeff.
I'm just wondering if there's any room for going to the patient group and asking them to help us, really. Something like, something mutual help meeting would be very interesting. It seems that we have a group there who could. I mean, obviously not everybody, obviously not all the time, but there might be times when the ward's a little bit quieter, or perhaps feelings between staff and patients are a little bit less fractious, and we could say we're interested in this. We'd be interested in somebody, perhaps at discharge, kind of giving us what was it like from your perspective. learning in that way, opening it up to the patients themselves, maybe people like advocates, maybe some other way of gathering that information from a kind of localized basis.
Yeah.
I'm finished.
Okay, yeah. Yeah, that's doable. Okay, I'm going to consider that question answered, or at least it's answered, Ole, as well as we can answer it at the moment. Do you want to, I'm going to give you the floor, Ole. Is there anything you want to say in response to the answers you've got to that question? Oh, it doesn't look like you've got a working microphone, Ole, so we're stuck with just what you're managing to type into the question box, which is the latest you put in is that challenge training's a good idea. We've got some sessions a bit like reflection, but it's more from the staff point of view. He's going to try and introduce some challenge training on these sessions. Okay, let's move on to the next slide, which is about difficulties and issues in the reassurance intervention. The one that comes up often in the sessions of talks and workshops that I run is the issue about confidentiality. How much can you share about the reasons for another patient's difficult behaviour on the ward with other people? Well, I think your first safeguard here is to talk in generalities rather than necessarily talking about an individual patient. So you can talk about, say there is a patient who is angry and shouting on the ward. You don't necessarily need to talk about that particular patient's situation or behaviours, but you can speak in general about reasons why people become angry and shout while they're on psychiatric wards, and you can say that the staff are always aware and the staff will always come running when there is any shouting on the ward, and the staff will be there to protect and deal with any situation that might arise. So you're not actually conveying any confidential information in that kind of situation. However, you also need to accept that patients know a great deal about each other through proximity because they're all living in the same environment, and it's really not worth pretending to ignore the stuff that everybody already knows. So everybody might well know that Fred is hallucinating because he's continually talking about it and talking back to his voices, and the staff are continually publicly interacting with Fred about the fact that he's hearing auditory hallucinations. So everybody already knows that. So when it comes round to giving people reassurance about the fact that Fred is shouting, it is pointless to ignore the fact that Fred is auditorily hallucinating because everybody knows it. So you might just as well talk about it and deal with it. I think if there's a safety-related issue, then that trumps any boundaries in this particular case. So if there is a patient on the ward who really should not be approached in a certain manner, as that might be risky, then it's quite reasonable to advise other patients not to approach them in that manner, and giving them some kind of reason as to why that is the case. And as kind of a last resort, I suppose, you can talk about the coarse contours of an issue versus the details. So in order to hark back to my Fred and his hearing voices, you can talk about hearing voices and the sorts of things that voices may or may not say without revealing necessarily details of what the specific hallucinations are that Fred experiences that you know, and obviously he knows, but are not part of a wider knowledge amongst the patient community. So those are my kind of loose kind of thoughts around confidentiality in relation to the reassurance intervention. Another difficulty, I think, with reassurance in some cases is that our ability to reassure patients depends on our own ability to reassure ourselves. If we can't contain our own anger and frustration in relation to patients' behaviour, then there's no way we can help patients contain theirs, because we can't communicate a held or contained situation. So if we've got a really, really frightening and threatening patient on the ward, unless we can actually contain within the team itself our own feelings of fear and anxiety about dealing with this particular patient, then we can't convey a contained and controlled situation to patients. Therefore, the battle for reassurance starts within ourselves and within our own team and within the team's level of mutual support and management of our own emotional responses. And if we're getting stuck at that stage, then we need to deal with things at that stage before we can get on to going out and giving the reassurance. It's pointless going out and giving reassurance to people where patients can see that we remain frightened and upset ourselves. So what did I mean here when I put staff time on this? Staff time to actually give the reassurance. This is one of the difficulties. If you're on a frantically busy acute psychiatric ward, or say you're on a triage ward that's having people coming in and out, admitted and discharged all of the time, it becomes more and more difficult, especially if there's a lot of patients on the ward, to actually do the reassurance, because you've got a long list of tasks that everybody is working through, stuff that people are doing, important stuff that everybody is doing in order to facilitate people's admission, discharge, introduction into the community, dealing with the treatment that people need. So if staff time gets compressed on a busy shift, then it's hard. And I'm not entirely sure that I've got any advice or means that I can give you that will make that more possible, except that to say, if you can stop the contagion from happening, you're actually in the longer term saving your time, because you won't have to deal with the subsequent incident and all of the fallout from that incident. It also takes staff emotional space, which is kind of a different angle of the same issue, really, is that you've got to be able to process your own emotional responses to patients' behaviours before you can actually go out there and deliver the products of that processing, deliver that equanimity, that you have to be calm within yourself to deliver or to lend, as it were, that calmness and that relaxation to other people. You have to attain that, and to attain that you need your own emotional space for processing. And then the last question on there is again harking back to the question of Ole, really, is how do you maintain sensitivity of perception? Only in this case I was thinking about it from I suppose a more personal point of view, instead of posing it as a question of how do you maintain the sensitivity of the team, or how do you maintain the sensitivity of other people. There's more a question of here is how are we as responsible professionals to maintain our own sensitivity of perception, because there is a natural wearing down process of working in psychiatry long term. It's an entirely normal human response that we get used to things and routinized into things, and it's how we deal with that ourselves. How do we keep our own perceptions fresh? And that means, of course, that we need to challenge ourselves on occasion, or expose ourselves to new things, or garner those challenges, welcome those challenges in some way from other people. Opening this to the floor, are there any difficulties or issues with reassurance that I haven't covered here, or has this triggered any thoughts on your part? Would anybody like to speak? I'm really hoping that's a test. Yes, it's a test. I mean, if anything else could go wrong with this particular webinar, the building burning down would be it, really, wouldn't it? Any of you on the floor there, please, want to speak about difficulties and issues in reassurance? Nobody's got their hand up. Okay, Jeff, thank you. You have the floor.
I was just thinking back to perhaps some of the less I mean, we made an assumption here that most staff are good, and they are, and I totally believe that. But I have worked on wards where you go out to perhaps reassure a patient, and the feedback you get is that an actual staff member has managed the situation quite badly. And I think that's important to get, and not to be frightened to do reassurance and then take it back into a kind of a, think about how you're going to manage that. But often, reassurance can then lead into people ventilating kind of dissatisfaction with certain aspects of the ward. And I think it's important to say to staff that will happen, and not to be frightened of it, and perhaps just think a little bit about how we prepare people. And I'd be interested if people who have done it, whether they've kind of had that as well, that some of the reassurance kind of comes back as quite angry stuff, and that it's actually all right to be exposed to that. And I was thinking also then that, I've done a lot of debriefs, and I thought I'm kicking myself for a way, because what we really should do is reassurance first, and then bring that information into the debrief. I'm just sitting there thinking, God, why didn't we do that? What's the patient perspective? Have we had any feedback from the kind of reassurance that we've done? Really. Anyway, those are my comments.
Okay, thank you for that, Jeff. I've really not thought about the incidents that we hadn't handled well, and that's actually a critical point, isn't it? Because that's another way again of expressing the value of equality with patients, and we must be prepared to say as a team, well, we didn't do that. We really didn't do that as well as we might have done, and we're sorry for that, but we're taking that in hand, and we're going to do better next time, and certainly we generally do better than that. And acknowledge that with patients, because that level of honesty is going to get us further at the end of the day than trying to pretend that nothing is wrong. Okay, anybody else want to have a word on difficulties and issues with reassurance? No? Okay, I'm going to carry on. Are there any ways we can enhance or strengthen this particular intervention? Just a few ideas I came up with here. You might have some of your own, I hope. I think we could think about, or have some prior agreement amongst the team about the nature of any explanation to be given to patients, so that we promote consistency. If we say Fred's been shouting on the ward, and we're going to go around and reassure everybody, if that's one person, then that one person can go around and speak to all of the patients, and they will give a consistent response. But what about if one of the other patients on the ward picks up this same issue with another member of staff later on the same shift, or if we have several nurses going out onto the ward offering reassurance to the other patients? We should have some kind of consistent explanation here, or otherwise we potentially are going to confuse the patients as a group, especially if they swap notes afterwards. Well, what did they say to you? They said this to me. Well, it's not what they said to me. They said that to me. So it needs some care and attention. Might enhance the efficacy of this as an intervention. We might manage this better, point two, if we confer amongst the team about how to help individual patients understand each other's behaviour. So there might be patient-specific reassurance interventions. So there might be moments or times at which a particular patient might require a particular type of reassurance intervention or explanation about somebody else's behaviour that might help them move on, or change their particular responses, or change their perceptions. And it might be worth us thinking about what sort of reassurance message would benefit which particular patient in what particular circumstances. So you can see this starts to become quite a sophisticated rather than a simple intervention. And then I started to find my final point here about inoculation, or reassurance as inoculation. Are there any advanced explanations of certain staff or patient behaviours that we could give prior to any incident, or early in any apparent escalation cycle, or to new patients being admitted to an already a tense ward? So before the reassurance is needed, you give people some of those explanations so that they can correctly understand something that they then subsequently experience. So that would be advanced level reassurance intervention, if you like. Any of you lot on the floor out there got any ideas about on these, or about how we might enhance reassurance as an intervention? No, no hands coming up. I think that is the end. In fact, that is the end. Anybody who would like to make any final comments about reassurance as an intervention, positive or negative, difficulties you've experienced, triumphs you've experienced with this particular intervention? Any final comments? No? Okay, well, I'm going to sign off from this webinar then. Oh, Jeff, thank you. You can have a final word, Jeff.
Just some reassurance, that was very interesting then, to be honest with you. I know it's difficult, it was very interesting. My feeling is that this is probably one of those interventions that a lot of people say we already do this, and I think what you've done today for me is actually give me a lot of new things to think about in quite a lot of depth. So I want to thank you for that, because to be honest with you, this has, although the difficulties, been very interesting. Thank you.
Okay, thanks. A number of people passing and thanks under the questions as well. It was very interesting to give some further thought to reassurance, because the more you think about it, the more complicated it gets, and the more sophisticated it gets as an actual intervention. And you can see this could be done at many different levels, through to a fairly simplistic way, right through to quite complex and well thought out individual interventions with patients. Thank you all very much for sticking with this webinar and waiting for me to appear. You waited a long time, just as I sat here waiting a long time for what I thought for you to appear. Very sorry about that. Won't happen again next time. Thanks for sticking with it. Thanks for sticking with the difficulties that we had with the screen in the beginning, and thanks for your comments in the course of this webinar. Let's bring it to a close. Goodbye and enjoy the rest of your day.